right. Let me go ahead and just get my screen shared. Okay, Josh, can you confirm for me? Do you see the screen?
Yep.
The slides? Great.
Yep, they're there.
Then, great. Well, thank you everybody for joining us today. We really appreciate you all being here to talk about supporting residents with substance use disorders. Before we start, I just have a few logistics to share. Please just note, we are recording this session to be available for viewing after the conference. The chat is open for participation. So if you have comments or questions for the presenters, please enter them into the chat throughout this presentation, and we will get to them when we get to the Q&A. Today we have two presentations. The first is with our Johns Hopkins team who has joined us. In 2019, CLPHA collaborated with Johns Hopkins University on a survey of CLPHA's membership to better understand how public housing authorities are serving residents affected by addiction and what policies or resources PHAs continue to need. The intent of CLPHA's participation in the survey was to identify best practices for most effectively serving residents affected by addiction and to inform CLPHA's advocacy efforts on addiction issues. Today, we'll learn more about the results of this study from the Johns Hopkins team, which includes Craig Pollock, Associate Professor in the School of Medicine, Brendan Saloner, Associate Professor in the School of Public Health, and Aline Kennedy Hendricks, Assistant Professor in the School of Public Health. After this presentation, we'll hear about the PHA perspective from our friends in King County, Washington, including Christy Johnson, the Interim Senior Director of Policy, Research, and Social Impact at the King County Housing Authority, and Cassandra Jackson, the Regional Director of Sound Health. Following these presentations, we'll move into some moderated questions, and then we'll move into Q&A with the audience. So with that, I'm going to turn it over to our Johns Hopkins team to kick off their presentation. Please let me know if you have any technology issues. Happy to help.
All right. Hi, everyone. Thanks so much for having us here today. I am going to start us off. I'm hoping you can all see my slides. Yes? Yes? Okay, great. So I'm going to start us off, and then my colleague Craig Pollock will take over. We're going to present findings from the survey that Camille mentioned that we conducted in collaboration with CLPHA in 2019 regarding how public housing authorities are approaching issues related to people with substance use disorder. So I'm going to start off by presenting some background information on the opioid crisis just to sort of orient us all to this topic, and then Craig will take over and present findings from the survey. So we are in the midst of a historically devastating drug overdose crisis in the US, which has worsened in the context of the COVID-19 pandemic. Even prior to the pandemic, overdose deaths were contributing to unprecedented declines in US life expectancy, and opioids are involved in the majority of overdose deaths, which is why you hear the term opioid crisis. And just so we're all on the same page, opioids are a class of drugs with pain-relieving properties and include legally prescribed opioid-based pain medications, as well as illegal drugs like heroin and fentanyl-contaminated street drugs. In recent years, we have also seen rapidly rising overdose mortality rates among Black Americans, highlighting important issues related to equity and availability of services to support people who use drugs and are at risk of overdose. So in recent years, oh, I skipped a slide. So in recent years, synthetic opioids like fentanyl have become increasingly prevalent in the drug market. And fentanyl is a prescribed medication used in medical settings, but here we're really talking mostly about fentanyl that is sold in the illegal drug market, and that's the fentanyl that's contributing to most of the overdose deaths that we see here. So since 2015, the number of overdose deaths from synthetic opioids like fentanyl has really skyrocketed. And this is a very strong opioid, so it can increase the unpredictability of drug consumption, making it difficult for people who use drugs to calibrate their dose. And fentanyl also sometimes shows up in other types of street drugs, like in stimulants. So it can cause overdoses in people who may have little tolerance for opioids. In addition to fentanyl contributing to the really serious overdose crisis we see today, overdoses have also risen in the context of COVID-19. More broadly, survey data suggest increased alcohol and drug consumption during COVID that is particularly heightened in people in essential occupations, essential workers, who may be more vulnerable in other ways as well. In addition, in 2020, we saw drug overdoses increase in every state in the country except one. Nationwide, the number of drug overdoses rose by 29% in 2020, and this is on top of historically high overdose death rates preceding the pandemic. So what do we know about the intersection of housing and substance use? So here you can see some data from a systematic review of studies of people experiencing homelessness on the prevalence of substance use disorder, alcohol use disorder, drug use disorder, and then dual diagnosis. And here we're referring to people with both a substance use disorder and a psychiatric condition, so a mental illness. And so these data show that there's quite a bit of variability. There's a huge range in the prevalence estimates from individual studies among populations experiencing homelessness. But when you look at that pooled prevalence estimate in the middle column, you can see much heightened kind of average prevalence in this population relative to the general population. So the directionality of the relationship between substance use disorder and housing instability is complicated. So people with substance use disorder may be at higher risk of housing instability, but then also people experiencing housing instability may be at greater risk of risky substance use. So one example from a recent study conducted just last year found that urban areas with increases in eviction rates saw significant increases in overdose mortality as well. There's also some evidence to suggest that there are interventions that can improve housing stability and substance use related outcomes. So research from the Moving to Opportunity experiment found that effects on substance use among adolescents moving to low poverty neighborhoods varied by gender. So low poverty neighborhoods played a protective role for female adolescents, so they used less substances, but heightened substance use among male adolescents. HUD's Family Option Study found reduced problematic substance use among people receiving permanent housing subsidies relative to those who are relying on existing services for people experiencing housing instability. And finally, there is some research, although it's limited, on this housing first model, which does not require participation in treatment in order to qualify for housing. And so this model has been tested most extensively among people with mental illness, but there is some research on those substance use disorders, and this suggests some potentially positive effects. A critically important way that housing and substance use intersects is through criminal legal system involvement. So a disproportionate number of people who are incarcerated have substance use disorder. And we know that substance use disorder increases risk of involvement in the criminal legal system, which can pose a serious barrier to obtaining housing in the community. So a history of involvement in the criminal legal system can increase barriers to obtaining housing on the private market, which can heighten the need for housing assistance. And then in addition, a criminal record can be a barrier to qualifying for housing assistance. So with that, I'm going to hand things off to my colleague Craig, but I hope this was sort of some helpful background to orient us all to this topic.
Great, thanks very much, Aline, and thank you to CLPHA for the opportunity to present these results on behalf of the group that we've been working with. And so what I'm going to be talking about now are the survey that we collected with working with CLPHA to distribute it to its members. And so for folks on the call that participated in the survey, we really appreciate you sharing your experiences. And so at the when we did this was in September to November 2019, so before the pandemic. It seems like a world ago now when this actually was fielded. And we sent out multiple emails. CLPHA kindly sent out multiple emails to its members to complete an online web-based survey. There was 43 of the members responded, so 63% of the folks responded. It was recently published online. The link to the report is in the chat. It is behind a paywall for folks that want to receive a copy of it. Feel free to send myself or Aline or other members of the team an email. We're glad to send you a copy of the report. And so when I'm going through the methods, I think some of it also speaks to some of the limitations of these methods. So this, again, happened before the time of COVID. So some of the kind of epidemiology of substance use disorder, as Aline talked about, is changing in the setting of COVID. Also, some of our approaches to housing assistance, for example, with emergency housing vouchers may be changing. So kind of some of the populations and some of the lessons may be a little bit different. This is also all self-reported data, and what I'm going to present to you is different housing authorities' experiences with different aspects related to substance use disorder. And we don't know whether kind of what we're going to talk about, how widespread it is within a housing authority. For example, if this is kind of across the board applied to all of their housing vouchers or all of their public housing, or just kind of model select programs. This also reflects only the views of large public housing authorities, recognizing that while they make up the largest share of the kind of federally assisted housing folks, that there are a wide variety of other perspectives to try to obtain. And then there's also kind of the idea that when we're talking about kind of working with service partners, we don't know whether the service partners are necessarily using kind of the best practices or evidence-based practices when they're working with their clients. Okay, so let me now kind of with those caveats in mind, let me turn to the results. I was just going to press forward, but Aline, you thank you. So when we ask people about kind of what are the approaches that they're taking to helping individuals with substance use disorders, we found that the vast majority of housing authorities, so 89%, reported using project-based vouchers for people with substance use disorders. We also found that 2/3 reported having permanent supportive housing models, which can be a wide range of different models designed to help individuals with substance use disorders. And just over 2/3 reported having at least some housing first programs. And those, for people that are unfamiliar, are programs that don't require sobriety for entry. They're housing first, and then kind of all other program support and participation can follow if clients elect to have that. We also noted that about half of public housing authorities reported having at least some time-limited recovering housing options, so to kind of help get people, for a short period of time. Aline, can you? Great. And so despite having some of the programs that I talked about, there was a tremendous need that was recognized across the public housing authorities, including nearly over 70% reported a need for new vouchers and for more permanent supportive housing in order to meet the increased demand for their individuals that they work with substance use disorders. In addition, we asked about kind of what sort of programs and partnerships do you have on site, and what sort of partnerships do you have with different individuals and different groups in order to meet the needs of the clients you're serving. And here we found that about 1/4 of public housing authorities noted the presence of on-site counseling for their clients. And a small portion also noted that they had some on-site self-help groups such as 12-step programs or Narcotics Anonymous. Here again, we asked kind of about what are the programs that you have off-site here in, as well as on-site in blue. And here we asked about kind of whether there was training and education around overdose prevention for the staff, noting that a relatively small proportion of housing authorities were doing this kind of in the 15 to 20% range. We also asked about overdose prevention for residents of the properties. And here's just over 20% note that either having offsite or onsite overdose prevention. In terms of naloxone prevention, naloxone, one of the drugs that can be used to reverse the effects of opioids. Here, the percentages are a little bit lower, as you can see, for both staff as well as for residents. And then in terms of sharps container for safe disposal of needles, you can see here that about a quarter of housing authorities reported having at least some of their buildings having on-site containers, fewer reporting access to off-site. And then a receptacle for getting rid of unused prescription drugs was quite low, with under 5% reporting on-site receptacles. This again, getting to some of what I talked about earlier with access to self-help groups, where there was about 40% that said that there are some off-site, and just under 20% that said they had access to on-site ones. Credentialing, counseling with credentialed mental health professionals, and then there are some that also have actual access to a health center or clinic offering addiction treatment. Relatively few offering on-site for those services, more offering off-site referral mechanisms. So let me now turn to the next part of the survey, which really looked at the criminal history, which again, Aline talked a little bit about kind of this complicated relationship between criminal history making you less likely to be able to stay stably housed and the barriers that people face. And one of the barriers that individuals with a criminal record faced is around access to federally assisted housing. And what our study results show was also demonstrated in prior studies, showing that there's a pretty wide variation in the criminal look-back period that would bar applicants from receiving housing. So about a third of PHAs reported look-back periods of 5 years or longer. And some small proportion considered criminal histories regardless of the time frame, so not at all time limited. The next slide shows a distribution showing kind of the number of PHAs that have less than 5 year look back periods, exactly 5 years, more than 5 years, or those without a set time frame. Again, showing that there's this distribution in the ways that these rules are being implemented. And even though we kind of look at these and ask about specific timeframes, we also note that there's a fair amount of variability in how these get implemented for individual clients, where some people, many of the housing authorities, nearly 88%, said that engagement in treatment could be a mitigating factor. So, again, you have a criminal history, typically it's 5 years, but if somebody is engaged in treatment, that may be a factor which allows them to get housing earlier. 70% note that their agency would be able to approve a public housing applicant or a housing applicant despite a previous drug-related conviction or possession. Okay, next slide. We also found that about 20% of housing authorities reported that criminal activity related to drug possession was a frequent primary factor in public housing eviction. So we know that, again, that criminal history related substance use disorder can be a barrier to entry, but we also know that there's a fair number of people that are leaving housing assistance or not eligible for housing assistance due to current criminal activity related to drug possession. And about a third of PHAs indicated that a resident is at risk for eviction, that there's a process for potentially referring residents to recovery services. So in summary, I think what this survey shows is that, together with the epidemiology that Aline talked about, is that substance use remains an enormous challenge where public housing authorities are in many ways on the front line trying to address the issues of housing for individuals with substance use disorders. And that there's a variety of partnerships that are currently in existence. There's certainly a tremendous need for new vouchers and new forms of housing assistance in order to meet the demand reported by the large public housing authorities. We also think that there's really tremendous opportunities in terms of sharing best practices, some of which is going on through sessions like this to try to implement things that could, for example, help with harm reduction. Some of these could be, for example, some of the low-hanging fruit around sharps containers on sites, access to naloxone and training for staff and residents around how to effectively use it. And also building partnerships that seek to kind of extend the boundaries, recognizing that not all of this falls within the purview of housing authority, but that working together in partnership with public health agencies can be a really promising approach that some of the housing authorities are already engaged in, recognizing that those partnerships take time to develop and often take resources that are incredibly stretched then. The final point is that criminal look-back periods can be an important barrier to housing, and that thinking through how those are being implemented in practice and codified in the rules and regulations can be an important step to trying to increase housing access for a population that often desperately needs stable, affordable, and safe housing. So I think that's it from the Hopkins side, and really appreciate the chance again to talk with you, and look forward to hearing the next presentation and hearing any questions that may come up.
Great, thank you so much. We really appreciate it. We will now turn over to our King County friends. They'll share the screen. Beautiful, I can see your screen. And take it away, Christy and Cassandra.
Great, thank you. Good afternoon, everyone. I'm Christy Johnson, King County Housing Authority's Interim Director of our Policy Research and Social Impact Department. As Camille mentioned, I'm joined today by my colleague Cassandra Jackson of Sound Healthcare. Cassandra and I have worked together, I think 16, maybe a few more than that, years, coordinating on various service-enriched housing programs that we have, in some cases, co-designed together and implemented across the county. We are delighted to be here today, even if virtually for now. And I really want to just give a big shout out to the CLPHA team for convening everyone today to talk about important issues like affordable housing, health, education, and partnerships. So first, bear with me here. I want to make sure I get my screen advanced appropriately. Got a few different screens up here, so bear with me just a minute. So first, I'd like to share a little, some framing about our community and the work of KCHA. So first of all, Washington State is home to 7.6 million residents, and about 2.2 million of those residents call King County their home. King County is the largest metropolitan county in the state in terms of population, number of cities, and employment. And King County has and continues to experience unprecedented population growth and low vacancy rates. This has really resulted in a decreased housing availability and affordability, and increased competition amongst renters in our community. The other thing I want to mention is in January 2020, 11,751 individuals were counted during our annual point-in-time count of people experiencing homelessness. This was a 5% increase from 2019. And similar to other communities across the United States, homelessness disproportionately impacts our BIPOC community members in King County. As part of our point-in-time count, our community does a survey following the days following the count of people experiencing homelessness. And as part of the 2020 survey, nearly 54% of the people surveyed reported that they had a psychiatric or emotional condition such as depression or schizophrenia, and nearly half reported that they were struggling with alcohol or substance abuse. KCHA was established in 1939, and we obtained our MTW status with HUD in 2003. We have an annual operating budget of $515 million and 440 full-time employees. We operate in 37 different cities across the county, not including the cities of Seattle and Renton, which have their own housing authorities. And today, KCHA provides rental housing assistance to more than 21,000 households each night. In 2020, our HUD-funded deeply subsidized programs, we served over 17,000 households. This was up slightly by 508 households from our 2019 data. And together, this represents 42,000 people and over 15,000 children who had a place to call home through our public housing and housing choice voucher programs. Of these households served in public housing and HCV, 33% were elderly, 29% were non-elderly but living with a disability, and 39% were families with children. The median annual income of our residents in 2020 was just over $10,000. And of all of our newly admitted households in 2020, 45% were experiencing homelessness upon entry. As an organization, one of our key objectives is to use our affordable housing resources to address the housing needs of the most vulnerable people in our community. One strategy we use to approach this objective is to coordinate closely with the behavioral healthcare and homeless systems to increase the supply of service-enriched housing for people experiencing homelessness or who have special needs. As an organization, we have been actively involved in systems level coordination with the behavioral healthcare and homeless system, along with the veterans, child welfare, and education systems for over 2 decades. Because this level of coordination really takes time and dedication, in 2005, KCHA developed its Homeless Housing Initiatives Division. This is a division that works really closely with other local funders, such as our county government, and in some cases, philanthropic funders, to really pool our resources together in order to fund service-enriched housing programs for people who need that level of service to either obtain or maintain housing in the community. We very much see ourselves as the safety net for people in our community who have no income or are on fixed incomes and without housing. In no particular order, this slide really shows some of the key strategy areas we have focused on to address homelessness for all populations, including people with substance use disorder. First and foremost, we've instituted a homeless preference across all of our federally subsidized housing programs. And in cases where there are supportive services that are connected to the program, we've reduced our criminal history screening to just the HUD baseline requirements of no lifetime registered sex offenders and no convictions for production of meth in federally assisted housing. In recognition that of the ongoing and persistent crisis of homelessness in our community, we also apply for every opportunity we have for securing new special purpose voucher funding from HUD in order to increase our capacity to help more people in our community. We also draw frequently upon the flexibilities of our MTW program to design and implement and test unique approaches to meet the needs of people in our community. And Cassandra will highlight one such example when she takes over the stage here. And since we've been at this for a while, we've also developed several move-on strategies from many of our service-enriched housing programs for folks who really don't need that level of services to remain stable in their housing. This really helps to free up the service-enriched housing unit to be able to serve somebody else who needs this level of support in order to exit homelessness. And because, as I mentioned previously, housing affordability in our community is scarce and wait lists are very long, KCHA also plays a lead role in our community with trying to prevent homelessness and displacement through the acquisition of housing that is at risk of losing its affordability because the property may be going up for sale. Since 2015, we've acquired roughly 3,000 units of housing that was at risk of becoming unaffordable. And last but certainly not least, we couldn't do any of this work without the plethora of partnerships we've established over the past 20 years with community-based organizations like Sound. These partners really have trusted relationships with the community that we're trying to serve, and their sweet spot is providing support services. This then allows our team to do what they do best, and that's house people and administer housing assistance. Because of these efforts and strategies, KCHA now administers a service-enriched housing portfolio of nearly 5,000 units. We recognize that a one-size-fits-all approach isn't going to get us where we need to be in serving our community. So as I mentioned previously, we leverage our MTW flexibilities to develop an array of supportive housing programs that are aimed at targeting the people we're trying to serve. Next, I'm going to turn it over to Cassandra so she can share some information about sound. A fun fact about Cassandra that I wanted to share, she's a bit of a historian when it comes to KCHA and Sounds partnerships. She has literally been involved in every single program that we have embarked upon together, which according to my count is roughly 10 programs dating back about 26 years. Does that sound right to you, Cassandra?
That sounds about right, Christy. Good afternoon, everyone, and thank you for having me. And thank you for Christy for that intro into the work that we do together. I'm Cassandra, and as Christy has mentioned, I have been a part of Sound for 26 years and have been involved in all of the initiatives that King County Housing Authority has embarked upon with Sound, and I have enjoyed that process. A little bit about Sound. We're over 50 years old, and we're the largest and most comprehensive behavioral health provider in King County. And that when I say behavioral health provider, I'm talking about mental health and substance use. We roughly have about 650 employees, and on a monthly basis, we probably serve about 8,000 individuals. So a lot of people that we serve in King County. We don't house all of them, but we're there to support all of the clients that we serve. We approach our service from a supportive perspective, and we implement a evidence-based service delivery model called Reaching Recovery, because we believe wellness and recovery can happen at Sound and through our interventions. And so Reaching Recovery is a model that has been tested and evidence-based. We use that model. It has 5 levels of care, starting with the ACT model, level 1, which is the most intense model of care, where we do active outreach to individuals who are a little hesitant or reluctant to engage in care. We use techniques such as motivational interviewing and wraparound services to encourage people to engage in care. We do meet clients where they're at, and the Reaching Recovery model is about giving people the right service in the right amount and the right service intensity at the right time. I talked about level 1, then there's level 2, and that's intensive case management. Those are people or individuals who are slightly more engaged in services, but they need a lot of support and treatment to move toward their next phase of recovery. The next level is level 3, and that's outpatient services. People are moving more toward recovery. They may need a little case management, but they're moving toward their own recovery, because this recovery journey is about theirs. Level 4 is outpatient therapy. Those are people who are getting therapy and they're ready almost to graduate from Sound and to recovery and move on. And then our last level is care coordination. Care coordination is just providing coordination with physical health, social services, and other things, just care coordination, not any case management. And so those are some aspects of Sound. We also believe in providing a safe place to live if possible, and employment. So employment is a big part of recovery if a client is interested in that. And providing housing is where our relationship with King County Housing Authority is most vital. And one we have worked on and tended throughout the years. Next slide, Christy. Just to talk about, next slide, Christy, sorry.
Sorry.
Just to talk about some of our services. This is just a slight array of our services. We provide mental health and substance use disorder treatment. We have some specialty populations that we serve. We serve the deaf and hard of hearing, and we are the primarily the only provider in the state of Washington doing such work. We provide services to individuals who have intellectual and developmental disabilities. Again, we are one of the only providers in the state providing a focused service for individuals with that issue. Then we provide forensic service, and which has grown over the last 10 or 15 years, is a service oriented toward those individuals leaving jails and prison to help them re-enter back into society and to meet the needs of some of their court designated requirements when they leave jail and prison. Again, we provide residential treatment, we provide supported housing, we also serve, we make sure that all are welcome at Sound. Whether you're a member of the BPOC, that's Black, Indigenous, and people of color, or the LGBTQ population, all are welcome at Sound, and we believe in that very strongly. We take an ardent and inclusive role in addressing historical and ongoing issues related to diversity, equity, and inclusion. What can a client expect at Sound? They can expect, when they walk through the door, a comprehensive assessment, and where we determine what their needs are and what their goals are. Not our goals, their goals across all life domains. We are a partner in helping them plan their treatment and their care and where they want to get. Those treatment plans are individualized based on what the client and or their family wants for them. And our services are designed to instill hope, because hope is most important in order to achieve recovery and resilience. Okay, next slide. Next, I'm going to talk about our Housing First program. And this program was initially created in partnership between King County Housing Authority, King County government, and the United Way of King County. So as Christy talked about, the King County Housing Authority is very instrumental in partnering with a plethora of organizations to create housing opportunities. They use their MTW flexibility to provide Sound with the Section 8 funding. We in turn, as Sound, master lease units in the community with landlords, where we became responsible for the rent, the utilities, and damages. As a result of that, we provided subleases to individuals who have a mental health or a substance use disorder, and we leased to them. Now, initially, when we first started the program, we used a scattered site model. And we were using private landlords in the community. Over the years, as those units became less and less available, with the assistance of King County Housing Authority project-based sponsorship, we have an 18-unit apartment building dedicated to individuals that come into the Housing First program. Many of these people who come into the Housing First program, they're not clients of Sound. So this is not something we provide to our clients. They're individuals who have been identified through our homeless outreach. We have a homeless outreach team, and they've identified people, and through using motivational interviewing and supportive, caring approach, they've encouraged the person to accept housing from us. This is housing that has very low barriers. It doesn't require that the individual engage in treatment with us. It just, they just have to be willing to be housed. Once they are housed, we use, as I said, our motivational interviewing strategies, harm reduction approach to try to engage that individual in treatment. Now, some clients still will not engage in treatment, but the part of the program that allows us to still make outreaches to them and to provide wraparound services, despite whether they're housed or not, is part of keeping them housed and keeping them stable in the community. And part of that fidelity to the Housing First model, King County Housing Authority, as Christy mentioned, they waived all non-mandatory Section 8 voucher eligibility requirements. So they've been a true partner in that respect, in terms of housing the 45 clients in this unit. And most, as I talked about the Reach and Recovery model, most of the people entering this particular program would come in at the ACT model, at the first level of engagement. And hopefully over time, and we've had several people who have been in the program for a couple of years, they're to the point where they are probably ready to graduate because they need less and less services. And as time goes on, if individuals need less and less service, we ratchet back our services, okay? We do take a harm reduction approach because we realize recovery, especially recovery from substances, is not a linear process. It has its ups and downs, and that relapse is a part of recovery. Next slide. Now I will talk about the Willows. The Willows is a very special program, and very special in my heart because this is a program that allows, it's very unique in King County, but it allows and offers the individual, a community, and a path forward. A path forward for mothers exiting substance abuse treatment and allowing them to be housed, allowing them to truly further their recovery, and allowing them to be reunited with their children in the property on site. And to me, that's an amazing thing that they can have their kids with them while they're in a supportive environment that allows them to continue their recovery and eventually to the point where they can graduate. It's 15 units, so 15 units with a mother, and I think one mother has 4 kids, and another mother may have 1 kid, so there are kids everywhere. Okay, just telling you, go to the property. But it's nice to see the kids, and they are happy, and they are happy to be with their mothers and their siblings. We do get referrals from Family Treatment Court. It's a low barrier admission again. And this project is backed again by King County Housing Authority's project-based vouchers. Again, they are a partner in this. And also, since it's transitional where the ladies get to be in the program for 2 years, King County Housing Authority has a graduation process whereby they can get permanent housing upon graduation. So they don't just go back to homelessness. They are allowed to move on and truly, truly graduate back into society. We do have we have 3 phases of treatment. The first phase, when a lady moves in, is really about focusing on individual basic family needs and pulling that family back together. The second phase is about group and community reintegration. And the third phase is really about employment. And that's where our employment services could step in and help the mother find employment, find a new apartment as she gets ready to graduate. In some cases recently, some of the mothers use their stimulus money to get a car so that they could actually go out looking for jobs, which we thought was a fabulous thing. We also provide on-site mental health treatment and substance use disorder treatment. Now, granted, it's the pandemic, so some of these services have been provided both to Housing First and the Willows remotely through telehealth services. And we do have staff on site, support staff 24 hours a day, so that anyone who needs some additional support, they can just go and access staff to get that support. Our Child and Family Services team has also provided through Circle of Security parenting skills so that these mothers can become better parents as they get prepared to discharge out of the Willows. And I think I've shared enough about that because I'm probably over my time, but that is a program I can get very excited about. So thank you for that, okay?
Great. So thanks, Cassandra. It gets me excited hearing about these programs again, even though I'm in the weeds of these programs on the daily. I think the next thing we just really wanted to share with folks is some of the key considerations when you're thinking about lifting up programs of similar type in your housing authority or in your community. The first thing is really partnerships. I think you've heard throughout, Cassandra and I's and even Johns Hopkins folks' presentations, partnerships are really key. And I think, getting in at the systems level is always really helpful because it can add real value towards your efforts to ensure that services are interwoven with the housing resources for the best long-term possible outcome for families. The other thing I would just mention about partnerships is, and I mentioned this before, it takes time and coordination. So the thing that I would just say is that open and regular communication across the partnerships are really critical to the success of the partnership, the programs, and the families that are served. Cassandra, is there anything else you wanted to add about partnerships?
Well, what I wanted to say about partnerships is that it starts at the top. And I want to give a shout out to Stephen Norman of King County Housing Authority. Back when I first started, he was really committed and has been committed throughout the years to providing housing for special populations. So that's how we started with King County Housing Authority back 26 years ago. And it was through his vision and his mindset, and he hired wonderful people like Christy, who shared that vision, and other people at King County Housing Authority that really bought into the vision, as well as the CEO, the president and CEO of Sound, who has supported my work and my teams and other team members at Sound in working with King County Housing Authority. So that partnership began at the top, and then it trickled all the way down.
Yeah, really good point. The next thing we wanted to just mention is the importance of targeting the resources. As I mentioned earlier, getting involved with local community-wide efforts is helpful because you're going to find great synergy, energy, and quite frankly, resources to target specific subpopulations. And then I think the other thing I would say about targeting is, it's important in any service-enriched housing program that you're doing that you target people who really need the services in order to obtain or maintain their housing. And for housing authorities, I think the thing I would mention is having a preference for persons that are experiencing homelessness is also really, really key. And then finally, once you've identified your target population, I have always found it helpful as these programs mature over years to have that target population memorialized through a memorandum of understanding or a contract so that you're ensuring continuity across staff members that may come and go out of these programs of who the program's actually targeting. Cassandra, I'm going to turn it over to you to talk about Housing First and support services.
I believe, and we believe, that the Housing First approach is one of the best approaches to housing individuals with mental illness and substance use. Many of our clients do not have stellar credit ratings or backgrounds. All of those things need to be looked at. Many have been institutionalized, homeless on the street. So consequently, you have to be willing to step out of the regular box of landlord-tenant relationship and supportive services. It means you have to be willing to shift and make changes depending on the population that you're serving. Like I said, the perfect example is the Willows. That's a housing first approach model as well, but it's in transitional housing, but it's still the approach that we accept the woman or the mother coming in because of the ultimate gain. And this is very critical early on in defining that you're willing to be, and I'm gonna bring in the word flexibility, because the housing first approach is really about flexibility. It's about understanding that relapse happens, that even relapse from a mental disorder happens, and that there are things that may happen with the tenant / client that we can mediate because we're providing the support services, and that we can work with landlords and with ourselves as a landlord to mitigate a lot of the issues that may come up. And that is really the best approach. And the main thing is about crystal clear communication with each other. Because when you take a housing first approach, sometimes the roles may slightly shift, and you want to be able to step out and look at the roles and say, is this working? And can we have a good dialogue about, is this working for the population that we're serving? Okay. And moving on to support services, we do take a harm reduction approach. Absolute sobriety is not realistic all the time for people in recovery. And so recognizing that sometimes relapse will happen, when we master lease, if someone has to go into treatment for relapsing, they still come back to their apartment in their home, because we're providing the support services, and we're there to support them while they're in treatment and when they get out of treatment, so that it doesn't feel like I messed up or I have a bad mark against me. It's like, okay, you relapse. What learning can we do for this? What learning can you as a client, and we in supporting you, what can we take from this to better support you down the road?
Great, I think that's great, Cassandra. And then I think for the Housing Authority folks, I think it's critical to think about the services that you're going to be offering to the client served through the program, that is looking through a lens of what type of subsidy you're using. For example, the Willows uses project-based vouchers that really allows Sound to wrap the services around on-site. Whereas if you were using a tenant-based model or a sponsor-based model, you got to be real about what's going to be possible by way of service delivery to people in a scattered site model. So just wanted to note that. And I think that, ask yourself questions about, what will services look like? What are the expectations of service delivery? Will medication management be offered and a part of that service delivery? How will people who relapse be supported to maintain their housing? So these are just some critical questions, I think, that are important to kind of ask yourself on the front end. And then, we've talked about this a lot already, so I'm not going to belabor this, but flexibility is really, I think, central to any partnership. Partnership can be tough work, and it takes extra time. So just give each other grace, and be willing to flex up on how you do things in the spirit of coming from a client-centered space. So that could look as simple as, like, how will paperwork be filled out? What are the expectations for timeliness of paperwork returning, to how will inspections be conducted on the units? I mean, the list goes on and on, but I think it's just important to acknowledge that, one size fits all approach just doesn't necessarily work when you're serving pretty highly vulnerable people. So just keep that in mind. And then I think depending on the Housing Authority's toolkit, it might make sense to have an array of targeted approaches to serve people. That could look like project-based, sponsor-based, tenant-based, public housing. We do have a partnership with Sound and in one of our public housing sites as well. And then I know we're running a little short on time, so I will just dive right in, Cassandra, and then I'll turn it over to you on this piece. Be thinking about what's next. If it's a time-limited program, or if people don't need services in order to stay housed, but they still need affordable housing because they're not earning a livable wage, like just be creative and think bold about what move-on strategies might be possible within your organization. We've done this a couple different ways through use of our non-elderly disability vouchers for folks coming out of the Housing First program, to public housing options for folks coming out of the Willows. So we have a couple different approaches here, but I'd be happy to talk with anybody if they're exploring move-on strategies to share some of our lessons learned. Cassandra, is there anything else you would add, or should we turn it back over to CLPHA?
I think we can turn it back over to CLPHA. You have mentioned a lot of things about housing stability. The only thing I would add is that even though we don't require that people engage in treatment in, like, for instance, in Housing First, because it's, again, a Housing First project, we do ask that they allow us to come into the unit periodically. And that's so that we can eyeball what the unit is like. Sometimes that gives you a wealth of information about what may be going on with the individual's mental disorder or their substance use relapse, and you can intervene early. And that's the main thing, is trying to intervene early before it becomes too problematic to the landlord or for the client, and so that we don't have to go toward eviction. So I'll just end with that, okay?
Thank you.
Well, thank you all for those great presentations. So much rich information there. We are going to move into some Q&A now. I'm going to kick us off with some moderated questions, but as I'm doing that, please feel free to share questions or comments for our panelists in the chat. So both of you mentioned this a little bit, but I wanted to ask you a little bit further. How has the COVID-19 pandemic really affected the issue of meeting the needs of people with substance use disorders? And this is for everyone, so we'll let people jump in.
I can answer that because that is something that Sound has risen to the challenge for. We immediately developed what we called incident response team to follow the state and the health and CDC guidelines about COVID. And so we were mindful of trying to, because we realized we were essential personnel and that we still needed to provide services to our clients, but at the same time, keeping our clients safe and keeping our staff safe. So it was a challenge initially, because initially, I'll give you an example. In January 2020, we only provided maybe 3 units of telehealth services. Compare that to March of 2021, where we provide 32,000 units of telehealth services. We really expanded our capacity and capability because it was still about serving our clients. And so we never totally closed. We reduced staffing to address the risk, and we tried to follow the client. There were some clients who want to be seen telehealth wise, and there are clients who wanted to come into the office. So we tried to manage how many people and how many clients were in the office at any given time. Many of our SUD groups, substance use disorder groups, are held by telehealth, and actually many of the clients do attend those groups. Even at the Willows, the groups became through telehealth, just so that we could reduce the capacity of a large group, 15 women together in one room. We wanted to reduce the possibility of transmission. So people had laptops and things in their room which they can engage in care. So we have done things like that to engage our clients.
I'm on mute. Does anybody else want to respond as well? Thank you.
Hi, everyone. I'm Brendan Sloaner, the silent presenter from Johns Hopkins. So I would just share that in a separate study, we've been doing interviews with people who use drugs, clients of drug treatment programs and harm reduction programs, and just a few things that I think are important to think about right now in terms of people's challenges. More people are saying that they're using drugs alone. I guess that's not that surprising, but that really increases their overdose risk. And people are also talking about a drug supply that has become a lot more unpredictable. People are not necessarily able to use the same drugs that they may have been using pre-pandemic, and that has important implications for harm reduction because people may be finding themselves in riskier situations. My colleague Aline was sharing, the fact that we are in a historically high overdose risk period. So the importance of harm reduction efforts, I think, is vital right now, and especially with rising housing precarity and all of the economic strains that people are under, having a roof over their head while they just get through this incredibly difficult time is really important. Anyway, thanks for the chance to be part of the conversation today.
Sure. Thank you for joining us. So my next question for our panelists is, what have been some of the main challenges in building these programs, and what have been some of the main pushback that you've received?
Well, I'll lean into that, and I think Cassandra can speak to this a little bit more articulate than me, but I think it's fair to say that, funding for behavioral health services, which includes substance use, never feels like it's enough to meet the need in the community. And I think, being able to pair resources, I would push that even out with the housing choice voucher opportunities too. I think that it always feels like we're a bit behind being able to meet need, which can be challenging, and it's just frustrating because reflecting back on the Housing First program, like we had a philanthropic funder in there, and when their priorities changed over years, right, it was a scramble to fill the gap so that we could keep the program whole. So funding is always a challenge, just trying to, right size it to meet the need in the community.
I would add to what Christy said is that funding is always tantamount to trying to keep programs whole, keep them going, and be able to pay our staff a wage that allows them to live in King County. Many of you all are not from King County, maybe on the East Coast. You have your challenges in your cities. King County over the years has become a very expensive place to live, and consequently very difficult for our staff to do the work that they want to do in this area. So that's a challenge. And then really understanding the population and the clients and what they want and what they're willing to accept is always going to be a challenge, because each group of client is going to be slightly different than the group before. So you can't always go with one cookie cutter approach.
If our friends over at Johns Hopkins don't have anything else to add to this, I would say some of what some pushback in this space that I've seen over the years has really been about commingling people with substance use with other populations that maybe don't have substance use issues, and just some concerns about what that might look like. We haven't necessarily seen that play out at the Willows because the whole property is dedicated to people that are in recovery. So there's a community there that's working towards recovery together. But I think it's fair to say that, you know, if those were all tenant-based vouchers, right, it would be a different conversation with the private market landlords about why they should be taking a chance to house, you know, to reduce their screening criteria or their look back periods to house somebody that is in recovery. And I think it's always a careful balance when you're talking about serving people that have experienced homelessness or substance use disorder to, you know, market them to the landlord in a way that's appealing, right? And really what that looks like is, you know, we're here to support the person. If you have an issue or you see an issue on the property, we're here, you can call us, right? You don't have that advantage with other community members that may be struggling with similar issues. So I think it really depends on the model that you're trying to utilize to serve this population. But those are just some of the things that come top of my mind.
There's a point that I want to shoehorn into the conversation here, which is separate but related. And that is this point about beds. So in the policy discussion around our addiction crisis right now, there's a huge recognition that people who have substance use issues need beds. And ultimately what that ends up getting translated into is they need to be put in kind of very clinically intensive residential treatment programs. Whereas oftentimes the best setting for them is some kind of normal housing environment without 24 hours kind of clinical staffing, very expensive kind of environment. So I think there's also, just speaking to the housing community, there's an important point that you guys could be kind of advocating for some of those resources that are going into this very kind of specific intervention to address the housing needs of people who have substance use issues, instead of sort of being so focused on residential treatment programs as the standard place where people need to go. I don't know whether Aline or Craig want to say anything about that point.
I don't have anything to add. I think it's a great one.
Great. Well, I'm going to elevate a question from our audience. We have the question of, how does 211, which is the information resource hotline in a lot of communities, partner with these programs? Are you all aware of 211? So do you all work with them? Are they a source of referrals, or do they have a way of supporting people with substance use disorders?
In our community, yes, if you're referring to coordinated entry, we do have a coordinated entry program in King County. It's not specific to the Willows, but it's specific to some of the other housing programs that King County Housing Authority has. And so, yes, we do use that for people to enter into housing in King County. Yes. Would you want to add anything to that, Christy?
I think the only thing I would say is in both of the case studies that Cassandra and I shared, the referrals are not exclusively from coordinated entry. Willows doesn't take any referrals from coordinated entry. Housing First can take referrals from coordinated entry, but the primary resource of people is through street outreach.
Mm-hmm. Yeah, I find 211 to be a really interesting community resource that I've seen other community-based organizations have some real success. One with like understanding need, particularly during COVID, and meeting the needs of people, particularly around housing and food insecurity, and receiving mental health services. That's a little bit different all across the country of who they're partnering with and whatnot. But really interesting service there for the communities that do have it. Okay, well, moving on to another question of, what policies can the new Biden administration enact to support housing for people with substance use disorders? And I think my King County friends wanted to kick it over to our Hopkins friends first to see if you had any suggestions.
I guess I will say that as we were talking here, that had published a notice about emergency housing vouchers. So I think that it's great to see that those that funds have been allocated for that. And I think it'll be really interesting and important to see how that the money is distributed for those vouchers and to what extent individuals with substance use, clearly they're going to be targeted towards individuals that are homeless or at high risk of homeless. And as Aline talked about, kind of there's this huge overlap in these populations. So I think that there's certainly possibilities here that will kind of play out over time.
So I'll just jump in on this a little bit. I would say that I'm definitely not an expert in SUD services or how people access them, but I would say that, I've had friends and family that have been impacted by substance use disorder. And, I know a little bit about this, enough about the system to be a little bit dangerous, right? But I say that because when I have talked to people that have been struggling with addiction issues in my own life, one of the things I hear is like, it's so difficult to find how you can actually get treatment when you're ready to get treatment. So I do not know, necessarily what that looks like, but I think an interesting thing that I've heard kicked around is this whole concept of treatment on demand. And, I think that there's a lot to unpack there, but there's a lot to be said about that, right? Like when somebody's ready to get clean, then you want to be able to support that person wherever they're at. And to the point Brendan was making a moment ago, like not everybody's going to need an inpatient bed, right? Some people just need supports wrapped around them and help them navigate the system. So I would just say that, it would be interesting for them for the new administration to approach it from a slightly different lens than what it's been approached over the years. And I think I'd be remiss if I didn't say that I think there's never enough housing resources available to meet the need. So, while there is this $5 billion worth of vouchers coming out, we know that it's really only going to scratch the surface. So I think that it's important to continue to elevate affordable housing at all levels of this conversation, whether it's for people experiencing homelessness, people dealing with substance use disorder. I think there's always going to be a need for affordable housing. And I would go so far as to say that I think there's also a need for housing authorities to have flexibility to be able to model those appropriately. We know that giving somebody a tenant-based voucher is not going to work for everybody. Right? There's still hoops that they're going to have to jump through to get into housing. So I think having an array of models and resources at the housing authority's disposal, is going to be critically important.
Yeah, and just to, oh, go ahead.
Oh, go for it.
Oh.
I'm going to say I agree with Christy. I'm not an expert on where the Biden administration is going or HUD. I do know agencies in King County, especially like Sound, attempt to provide treatment on demand, because we do recognize when someone's ready for treatment, whether it's mental health or substance use, they're ready. And giving a person an appointment 2 or 3 weeks out, many of them 2 or 3 weeks out won't show for that appointment. But if they can walk in today, get an assessment, and begin their recovery journey, they're more likely to stick to it. So that's one of our philosophies of care, is about trying to grab the person when they say they're ready for treatment.
Great. Aline, do you want to share?
Yeah, I was just going to echo what Christy said with respect to sort of flexibility in terms of resource use and how housing authorities are allocating the limited funding that they do have, because I think the models that Cassandra and Christy both highlighted, which are just so fantastic and amazing, you've been able to do by being flexible with people. And that's just so critical for the population of people with substance use disorder, having that flexibility. And so giving housing authorities sort of, I think, the ability to be as flexible as possible with these populations, I think is just critical from a policy perspective.
Fantastic. Thank you. Well, I'm going to let that be our last comment of the day. We are at time. Thank you so much to our panelists. This has been really great and great conversation and lots of information that I'm sure I'm going to take away and use soon. So thank you again. Just a quick reminder to everyone who has attended, we do have a survey to receive feedback about the events. You'll be getting an email this afternoon about it. So please take a few minutes to just let us know about how today went. That'll be in your email. Thank you again. I hope everybody will join us tomorrow for our final day of the conference.
Thank you.
Thank you.